So at the outset, I would like to cover up the entire thing for this instruction course. I'll be covering up not only the retained nuclear fragments, I would also be covering up other aspects that are associated with the posterior capsule rupture. It's actually an honor to see so many people out here at this time. Thank you so much. So initially, I will be just showing a few animations which, they just explain how things actually work. For example, this animation, it just shows that, okay, when you are doing a phacoemulsification, and suppose if you happen to capture the posterior capsule, do not just directly withdraw the phacoemulsification probe from the eye just because you are scared. The best thing to do at this moment is to press the reflex button, and then you can even start injecting viscoelastic from the side port incision, so that in case even if you have a posterior rupture, it's not going to enlarge. The OVD that we try to use here is usually a dispersive OVD, which tends to seal the posterior capsule defect very well, and only after you have sealed it, you would just pull the phacoemulsification probe out of the eye. So this is one of the ideal situations to handle with. If you have a situation where you have a small posterior rupture, as we showed initially, and you have a vitreous coming up into the anterior chamber, one of the most important things is to seal up that corneal incision, make a side port, have a fluid, and here, if you have a small PCR, I would not recommend, if you're actually not very well versed with vitrectomy, at least do something in the anterior vitreous, cut off that small streaks which are coming up into the anterior chamber, put up a triamcinolone, see how much vitreous is out there, and you can just clear it off. But the situation, the equation completely changes if you have a big posterior rupture out there. Now, when you have a big rupture, I would actually not be recommending to do an anterior vitrectomy. Actually, the pars plana vitrectomy is the most ideal thing to be done in this situation. So you need to have a fluid infusion inside the eye. You can also use an anterior chamber maintainer at this point of time, but you need to make a posterior entry and do a pars plana vitrectomy. The ideal thing is to place up a trocar, shave off the vitreous that is actually bulging into the anterior chamber, and then maybe if you have done that, the limited amount which is there in the periphery, you can clear it up by doing a limbal from the limbal incision. So maybe you can use a combined approach out here. But the concept of doing a pars plana vitrectomy, as Dr. Shell and as Dr. Lalit Verma has also highlighted, it is a very important aspect. Now, what actually I have seen practically, most of the anterior segment surgeons, they have an inhibition to put a trocar cannula into the system at about 3 to 3.5 millimeters from the limbus. Believe me, it is one of the most simple things that you can do, provided you maintain the method of how to do that, and maybe any of your VR friend can help you with that. So that's one thing which can be very handy. At this point of time, I would just like to ask the audience that how many of you are actually doing a vitrectomy with the vitrectomy probe whenever you have a complication? Okay, so we have quite a bit of people. And is there anybody who is still using the scissors to do? Because all those people who have not raised their hands means either they have not have I don't believe you don't have a complication. Everybody has a complication at any point of time. So you will need a vitrectomy to do. I think all the surgeons who have just not lifted their hands, they should move into doing vitrectomies if you are a cataract surgeon. Everybody has a complication. If you say you do not have a complication, means either you are not operating or you are just lying. So we just need to accept this fact and move ahead. Well, I'll be just showing this video. Okay, now here, there are multiple situations going on. You have a small pupil, you have a residual cortex, but you have an intact rhexis. So what you actually do here is that, you need to see inside the eye. Without seeing, you cannot do anything. And in this situation, no ring helps you. You have to use an external fixator device, which is an iris hook, whenever you have a posterior rupture. If you put a ring inside, it's going to go behind at any point of time, and then you have one more complication that is added up. Okay, now we have a pars plana infusion going on in this patient, and there is a residual cortex out there, and trying to remove that cortex with the vitrectomy cutter in itself. So now at this point, it is very important that your vitrectomy cutter you're pulling the cortex, but you should not be cutting the margin of the rexus, because this margin of the rexus is going to be very important for you to place the intraocular lens. Now, whenever you are doing this, you have to be very careful of the cutting rate that you have set into your machine and the aspiration rate. The cutting rate should always be higher, the max level that your machine has put it off, and lower down the vacuum level so that you are very safe. The second most important thing is to take up a 3-piece intraocular lens in these cases. The ideal thing is to take a 3-piece lens. You can place it in the sulcus, and you can also do an optic capture in these cases. If you are not very well versed with doing an optic capture, even if you place it in the sulcus, it's very friendly. Please do not, for heaven's sake, place a 1-piece IOL in the sulcus in these patients. The haptics of the acrylic IOL, they lead to the development of UGH syndrome, maybe for some patients, maybe after 10-15 days, for some patients after 1 month, 2 months, 3 months. These patients will come back to you again with complications, red inflamed eye, raised intraocular pressure, and things like that. Always use a tricot injection, inject it inside, and just see if everything is okay, if there is no vitreous strand out there. Have a look at the pupil. I always try to have a look at the pupil because, you might have an irregular shape of pupil out there, because whenever your vitrectomy is not good, your pupil will never be round at the end of the surgery, and you actually do not want to have an optic capture in the postoperative period, because then what happens is that if your iris is flabby, or there's a chaffing of iris, it might go around the edges of the optic of the IOL, and then it might stick with the posterior. Anyway, there's no posterior capsule out here, but with any of the rexus margin or things like that. So you do not want any entrapment of the iris tissue coming up in these cases. Now, this is an animation. This animation describes the IOL scaffold procedure. Whenever we do phacoemulsification, whenever we have a retained fragments, if you have a good amount of rexus margin, I would recommend surgeons to do this. Now, there are various permutations and combinations to be applied into this. Always use a 3-piece intraocular lens for doing an IOL scaffold procedure, because at the end of the day, you are going to place it in the sulcus, and then you can use the optic of this intraocular lens as a scaffold, and then you can just phacoemulsify the remnant nuclear material, and then you can dial the haptics of this 3-piece IOL into the sulcus. So this is what actually an IOL scaffold procedure works like. There are various permutations and combinations in this. I would just come up to that in one of the videos. For example, I'm going to show you some worst case things which do happen in the ORs. So this is a case where phacoemulsification is being done, and here you see that the nucleus is sinking. This nucleus is not coming up. Whenever there is no followability of the nuclear fragment, you immediately understand that, okay, now there is some problem in this case. So you need to levitate this nucleus into the anterior chamber. There are various methods of doing this. It was lucky that it could come up from the corneal incision, or else you have to do a posterior assisted levitation, which I will show in the next video. Coming up to this case is that when the entire nuclear fragment or the entire nucleus is brought into the anterior chamber, just take a 3-piece intraocular lens and you inject it behind this nuclear fragment. You have to be very careful when you do this, because you also need to protect the endothelium at this point of time. Now, doing an IOL scaffold procedure, there are many times. For example, in this case, it's so hard nucleus out there. You actually do not see the leading haptic where it is. And whenever in doubt, when you have a trailing haptic, tell your assistant to hold it, because this intraocular lens should not slip and go back into the posterior cavity. Alternatively, many surgeons, they just inject this intraocular lens onto the sulcus, because if you know your rexus is very good, you place it on that and then you can emulsify. Alternatively, they also put the leading and the trailing haptic onto the surface of the iris, and then they do it. So it all actually depends upon the clinical scenario that you are actually having during the surgery. But in this case, nothing was seen. So it is always ideal to have a part of the haptic held so that you do not have any slippage. Now, this is not what I would recommend it, that, okay, you are done with the nucleus, so you are done with the surgery. No, there are many other aspects to be taken care of in this particular case. You need to go and also remove the remnant nuclear material which is there around this intraocular lens, and also something which has fallen behind into the vitreous cavity. Now, coming up to this aspect, suppose if you are an anterior segment surgeon and you are not very well versed with posterior segment, I would request to halt the surgery at this point of time. You can place your intraocular lens into the sulcus and you can immediately refer the case to your VR colleague if you cannot handle further, because vitreous is something that we all need to be very careful. There should be no ego in sending your patient to a VR surgeon, because now the remaining thing it's not done by the anterior segment surgeons. It has to be taken up by the posterior segment surgeon. Need to be very honest with yourself and also with the patient. So that is a very important thing. You remove the remnant nuclear fragments which are out there. And having done that, this is one of the most ideal things to do whenever you have cases like this. So this is one thing which I would always recommend. And then you would just remove the iris hooks. Check the stability of the intraocular lens, because this intraocular lens is placed onto the sulcus, hydrate the wounds, and just check if everything goes off okay with these cases. So now this is a case which went off and the patient had a very good recovery in this patient. Okay, now this is one case which I'm just trying to show you what actually is being done here. Now here there is a retained nuclear fragment. This fragment is not going to come up in any way. So when you put a trocar 3 millimeters from the limbus, already flaps for glued IOL are made in this case. So what we try to do here in this case is that you need to levitate this into the anterior chamber. You insert a rod from the trocar and try to bring this nuclear fragment into the anterior chamber. Once you get this nuclear fragment into the anterior chamber, then you have a different modality of how to go ahead and handle this case. Now, this is actually what is happening here is that we need also to do a secondary IOL fixation. So the procedure of choice is always a glued IOL procedure, trying to cut off all the vitreous which is behind this nuclear fragment. Because when you are injecting the intraocular lens, you do not want any dragging of the vitreous happening. So try to play safe as much as possible. But again, this technique can be done only by people who are actually very well versed with doing a glued IOL procedure. Because this procedure, I would not recommend anybody doing it if you're actually not very well versed with the handling of the haptics, externalization and all, because it's not that easy to do. So this is the leading haptic which has been externalized, and then this is the trailing haptic which is being managed. It goes from left hand to the right hand. It is the handshake technique. Nothing is seen. It's only the experience and the tactile sensations between both the hands that okay, now your left hand has hold the haptic and now you can free off your right hand. Again, go back from the sclerotomy site. Again, hold the haptic and then pull the haptic from that side. So then you have this, this is a small trick, there is a small area where you have a visibility. So you can hold the tip of the haptic from that area and then you can just pull off the haptic. So once you have both these haptics out, you can tuck these haptics. We also use the iris hooks, the plugs of the iris hook we often use to slip onto this haptic so that it does not slip anywhere. The IOL and the haptic remains as it is, and when we are done with all the manipulations inside the eye, then we go ahead, release those things, and then we tuck the haptics, and then the things they get settled. But here in this case, only direct setting has been done. The haptics are just tucked into this, and then you have this fragment which is there into the anterior chamber. So now then you can just emulsify this nuclear fragment, and then be very careful. Actually, if you have a small pupil here, it is very beneficial because it prevents the slippage of any nuclear fragment from around the edges of the optic of the intraocular lens. But anyway, there will be some slippage or some cortical matter which will still be there behind. So again, you will always need to do a posterior vitrectomy in these cases, because you're not very sure of how, the things are going on. But at any point of time, I would like to say that you need to coat the endothelium very well in these cases. This procedure is not recommended if you have a low endothelial count, or you have a very dense cataract coming up, or a dense brown kind of a cataract coming up. The best thing is to maybe just extend your incision and get that hard cataract outside the eye. Another principle is always seal the corneal wound whenever there is vitreous. You should never, even if you have done a good vitrectomy, never leave the corneal incision as it is. You need to take a suture, seal up things, put up a fibrin glue, and do up the things. So anyway, I would like to show you much more interesting something for the anterior segment surgeon. So now have a look at this. This is an Ozurdex injection. This Ozurdex injection was injected and there is a posterior rupture. It has not gone into the vitreous cavity. It has not gone into the vitreous cavity, and it has ruptured the posterior capsule, and it lies within the lens. So I'll just forward this a bit just for the benefit of all. You do a Rexus, and this Ozurdex, anyway, it comes up very easily into the phacoemulsification probe. You do a good IA at this point of time, but you know that you have a posterior rupture. So go very, very slow when you already know that this element is there into the anterior chamber, and you are going to expect a certain amount of posterior capsular dehiscence in this patient. So carefully and diligently doing an irrigation aspiration in this patient, most of the cortical matter is just removed, but yes, now things have started to show up that, okay, there is going to be a small opening out there, but it seems that there is no frank vitreous that has come up, but yes, there is an opening out there. So now this is a point you should not be fishing at that point, because the vitreous is already there. So best thing is take up a vitrectomy kata and try to do a vitrectomy. Now if you do it, this is the difference. When you do it from the limbal vitrectomy, you're never satisfied, because the vitreous keeps on pulling and coming into the anterior chamber. But when you go from behind, you shave off everything which is bulging into the anterior chamber, use a triamcinolone, and then you will see each and every small strand which is there into the anterior chamber, and then maybe you can clear up things which are there into the anterior chamber. So having done this and clearing up everything out there, then you are free to use, your intraocular lens. Anyway, I would always recommend, whenever you are taking up any challenging case, have a 3-piece intraocular lens standby, because you actually do not know when you would actually need it. And what happens is that actually I have seen surgeons, you do not have a 3-piece IOL standby. And so what happens is that, you are forced mentally that, okay, I have to put the lens somehow, what will I go and tell to the relatives? Nothing of that kind, because that becomes a very tricky situation. So I think it is best to have the stock of 3-piece intraocular lens, few lenses into your armamentarium. They can be really helpful to you whenever it is actually needed. So this patient actually behaved very well in the post-operative period. This is one case, I would I'll just see the time. Okay, I'll just 5 minutes more. Okay, this is a case which was again a referred case. This patient had a very high refractive surprise, because patient was probably operated when the patient was a kid. So we need to explant this intraocular lens, but YAG opening was there, and there was a lot of fibrosis out there. So what I'm actually trying to do here is that, trying to remove all the adhesions which are there around. And actually I had decided that, maybe I will cut this intraocular lens. So I take up the IOL cutting forceps in this, but then I eventually realized that, okay, this intraocular lens is a PMMA IOL, and there is no way I can cut this intraocular lens with any of the forceps that I would actually have. So the best thing is to just explant this intraocular lens. I had to enlarge this incision at this point of time, and then, I just removed this. But there is a fluid infusion going on in the eye at this point, and that is a very important thing. And then I would just take in and replace it with a 3-piece intraocular lens, which is placed into the sulcus. What actually is important in these cases is that, this eye had, nevertheless, we did a refractive exchange for this patient, but there was a very persistently dilated pupil also in this patient. So it was very essential to do a pupil repair also in this case. So this is what I'm actually doing, is the single pass 4-through pupiloplasty procedure. So this is a 9-0 polypropylene suture which we take up, and I'm trying to close this from the, trying to pass this from the anterior and the posterior and the proximal side, and then this is the loop that we try to withdraw and hold it with an end opening forceps. We pull it out, and then we take up 4 throws. So this is the principle that it actually helps to do a pupilloplasty procedure in these situations. In these situations, actually, it is also very important to do a pupil repair. Many times it is for photophobia, many times it is for cosmetic reasons, many times it is also to prevent any optic capture coming up in the postoperative period. So I think this is very essential for everybody to learn how to do a pupil repair as and when it is actually needed into this. And another important thing, advantage of doing a pupil repair is that, actually it acts as a physical barrier between the anterior and the posterior chamber. Like, for example, in this case, you have this intraocular lens out there. So now you have those periphery open. If you have that periphery open, whenever you do a pupil repair, it closes down. So there is an anterior and the posterior demarcation which comes up. And I have seen many cases, they also have endothelial decompensation. So this is again where a pupilloplasty procedure works very well, because it does not allow any vitreous to come into the anterior chamber, and the success rate of an endothelial keratoplasty procedure being done at a later stage, it increases massively because you do not have any vitreous in the anterior chamber. So that is one of the another benefit of doing a pupil repair, specifically in these cases. So this is the single pass 4 throws taken, always taken in the same direction, and then you just pull both the suture ends, and then it beautifully slips inside, and then you can just cut them off. So you take up an end opening scissors or a long arm scissors, whatever you have into your system, and you can cut that suture. Always stain. I have a habit. I always use a triamcinolone at the end, and always to make sure that everything is going okay inside the anterior chamber. So these are, I think, some of the things that I would just like to share. I think I would like to stop here, and I would like to invite discussion from people, although I have lots of presentations pending, but I think we should be having some sort of discussion coming up.
Absolutely. Dr. Priya, excellent array of cases. I just have one reservation with the IOL scaffold, particularly in the cases that you had showed. Would you, particularly when you're doing a 3-port pars plana and you're going to do a posterior vitrectomy, do you think it would be safer to do a lensectomy from behind rather than dragging the nucleus in front, putting an IOL behind and doing a phacoemulsification above it? Because, like our cataract surgery outcomes have improved, I think the lensectomy outcomes are equivalent to almost phacoemulsification.
Absolutely. Yeah. For the lensectomy, I would like to say that, yes, if you have a soft, I didn't show that video. Yeah, if you have a comparatively softer nucleus, it's very easier to do a lensectomy from behind. And it is actually advisable, because you shave off everything from there and everything gets clear from there. But when it comes up to a very hard nucleus, whether you are doing anteriorly or posteriorly, I would like to have know what Dr. Gadre wants to say. I see him smiling. But the point is that, whenever you have a dense nucleus, and even if you have it into the posterior cavity, you have to have some methodology to remove that. So maybe, yes, maybe a posterior segment would do a phacophragmatome or something of that kind, and maybe for us it would be better to get it into the anterior chamber, and then we can manage it into our own system.
Absolutely. And I think the most important take-home message that I've learned from this entire course is never swipe your wound. So the habit that we have, that let me swipe the entire pupillary area and let me swipe at the incisions to see if this pupil is becoming round or not, that causes the maximum amount of intraoperative vitreoretinal traction. So whenever in doubt, just put diluted triamcinolone, just put BSS, and the vitreous will get stained, rest of the part will wash out, and that's the best way to find out if there is vitreous stuck in the wound or anywhere in the pupillary area.
Absolutely, absolutely. Any questions, please? If anybody has any questions, please use the mic to ask. Can you please switch it on for them? Okay. Yeah.
So, just your management for macular edema in such cases.
So I think these patients are going to require more anti-inflammatory treatment, and it may require anti-inflammatory as well as IOP lowering in the early post-operative period due to inflammation. So these are the cases where, along with, I kind of use topical steroids, prednisolone acetate. So even if you're normally using dexamethasone, this is the eye where you want to use prednisolone acetate for maybe at least 6 weeks, tapering over 6 weeks, and I would not hesitate to continue using the NSAID eye drops like Nepafinac or Bromfenac or whatever molecule that you're preferring for at least 8 to 12 weeks post-operatively.
Absolutely.
So, Dr. Priya, I had reservation for the case in which you used IOL as a scaffold in a brown cataract. So, I would recommend that either you take out the nucleus in toto by enlarging the wound or converting the wound to a SICS wound. Doing phaco in such a brown cataract in AC would compromise the endothelium.
That is what I said.
Yes.
That actually you have to pick up what you actually want to do and what actually you are well versed with, and what actually you can predict that how this surgery will unfold into your hands. Otherwise, it is always safer to just extract the
You can enlarge the wound, put few sutures.
Absolutely.
That's a better option.
You can make a scleral incision, you can enlarge it and then seal it and then do a vitrectomy, then fix up the IOL. So it can go that way also.
Yes.
Yes.
And I think another most important take-home message is that you must have a 3-piece backup. So, one thing that we follow when we order an IOL, we always order a backup 3-piece IOL along with it. We return the 3-piece at the end of the day once the cases are over and it's not being used.
But Salish, you did not show any case with 3-piece IOL. In all your cases, you manipulated the posterior capsule, converted into rexes and tried to place single piece IOL in the back.
Yeah.
So not all surgeons are that much talented. So you should show the
absolutely.
simple
So
procedures.
3-piece is something that we must have, and the safest option is to put, like Dr. Priya showed, 3-piece haptics in the sulcus and capture the optic through the anterior capsular rexes. And like Dr. Priya mentioned, that even if you are not able to capture, say if there's an anterior capsular split, if you put a 3-piece in the sulcus, it's going to behave very nicely if you take care of the early post-operative inflammation.
Absolutely.